Class.
Hello everyone. We're here today to do a webinar or a couple of webinars for you on immune-mediated hemolytic anemia. So I'll introduce myself first and then I'll hand over to Helen. So my name is Jenny. I'm one of the medicine specialists at Langford Vets.
I'm Helen. I'm one of the ECC specialists at IMHA Vets.
Great. And so we've split this webinar into two parts. So we've got roughly sort of 15 to 20 minutes for each part. And this first one, we're going to be focusing on diagnosis of IMHA, primarily in dogs, and we might touch on cats a little bit if we've got time, but we'll see how we go getting through all of the important parts for you. And then the second one, we're going to be looking more at sort of treatment and managing the disease afterwards. Great. So I guess I'll kick off, Helen, and just ask you what sort of diagnostic criteria do you need to be really comfortable with the diagnosis of IMHA?
Yeah, that's I guess a really good question, isn't it? Because I think this is a disease that we see commonly and isn't always easy to make a firm diagnosis. I think for me, I need to see clear evidence of hemolysis, and I would be characterising that by an anaemia with a reticulocytosis, so a regenerative anemia. And for me, I would want to be seeing evidence of spherocytes on the haematology, with or without ghost cells, so other markers of immune-mediated destruction of red cells, and with or without some kind of positive agglutination test, either an in-saline agglutination test or a Coombs test. And if we have that positive test, that I think adds strength to the diagnosis. I don't think that it's essential to have that if you have a haematology that's consistent with IMHA. What's your take on diagnosis then? Because I think this is a bit of a minefield in its own right, isn't it? And what are your criteria for making a diagnosis?
Yeah, really interesting. And I think there are a couple of points that you mentioned I was going to pick up on as well. For me, an anemia definitely. I think it's very difficult to sort of quantify numerically, I suppose, because each individual patient has got their own reference range. But if they've got solid evidence of IMHA less than 35, but I guess probably usually they're less than 30, aren't they?
Yeah.
And then I really like to see a marked spherocytosis. Like I'm most comfortable, I guess, like you, if I see a marked spherocytosis and also evidence of sort of marked autoagglutination. Like that's what I really like to see. Like that makes the diagnosis really easy for me.
Yeah.
I'm probably less, I do find ghost cells helpful. I'm not particularly bothered if they're absent, if those other two features come through really strongly for me.
Oh, yeah, I completely agree. And I wouldn't feel comfortable making the diagnosis if there was just ghost cells without spherocytes.
Yeah, absolutely, because then we'd be thinking about other causes of hemolysis other than IMHA, which I suppose we don't see so commonly, do we? IMHA is our most common cause of hemolysis in dogs, but still we've got to keep our mind open, particularly with travel diseases and all of these things for other possible causes of hemolysis.
Indeed.
Yeah, great.
And I think, do you have like a cut-off in your mind for how many spherocytes you would want to see quantified on haematology to feel comfortable that this is reflective of IMHA?
Like really comfortable 3+.
Yeah.
So a really solid number. For me, I guess it's a qualitative guide, isn't it? But from the clinical pathologist. 2+, I'm happy if there are sufficient other evidence of IMHA that make me feel really comfortable that that's the diagnosis, and I've got no suspicion for anything else based on the history, my exam, my other hematological findings. I think when we get to 2+ and definitely 1+ spherocytes, I think perhaps there's a perception that spherocytes are always associated with IMHA alone, but often we see them, don't we, with quite a few other diseases, particularly GI hemorrhage, but other diseases too. So do you have the same sort of cut-off?
Yeah, exactly the same as you. I feel very uncomfortable with a 1+. For me, that's just not enough to support a diagnosis of IMHA unless there was loads of other really strong indicators. But generally speaking, for me, 1+ is not enough to make a diagnosis of IMHA, and I would be looking for other causes of blood loss or other causes of hemolysis. 2+, I agree with you. I think it's a bit of a grey zone. I don't feel totally confident with it, but if all the other clinical features fit, then I would be more inclined to say, yeah, this dog probably has IMHA, and 3+ is more of a very likely that it's IMHA.
Yeah, absolutely. And I think we both also mentioned, as well as sort of spherocytes being a really strong feature for us, we mentioned a regenerative anemia as part of the process, and you were sort of discussing a reticulocytosis. I suppose sort of out of hours, I know a lot of in-house machines now can provide a fairly reliable sort of reticulocyte count. But is that a requirement for you? Would you use other features if you've not got a machine that can give you a reading for that, or if you're agglutinating so much your machine's not being very helpful?
Yeah, indeed, which we see not uncommonly with IMHAs. I personally do like to always look at a blood smear on IMHA patients myself, and not to be trying to identify spherocytes, because I think that is very difficult to do. I think that is something that really should be done by a clinical pathologist. And I think in dogs, sometimes you can see them. In cats, certainly it's very difficult to identify them. But I like to look at a blood smear more to see if there's polychromatophils as an indication of a strongly regenerative anemia, and as a sort of a qualitative index. If there's like loads of polychromatophils, then I'll feel reasonably confident that the patient has a regenerative anemia. And I probably would rely on that more than a reticulocyte count from an in-house machine, because I think we know that that counts can be affected by other abnormal cells that might be present.
Yeah. And one of the other things we've both mentioned, I think, is a sort of evidence of essentially immunoglobulins on the surface of the red blood cells. And we've sort of briefly mentioned that can be your in-saline agglutination test that you do bench-side, which a lot of us are going to be doing out of hours, or a Coombs test in the lab. And I think we've got some different opinions on these. But I guess first, there's quite a lot of literature looking at how people perform in saline agglutination. What's your sort of standard approach with all of that information?
So I will tend to do 1 drop of red cells.
Yep. Out of a microhematocrit tube.
Out of a microhematocrit tube. And then 10 drops of saline, which I typically do out of a syringe.
Okay.
And sometimes I do less than that if it looks like it's going to run off the side, and give it a bit of a swizz round. And to be honest, if I feel like it's not a completely defined thing as to how to do the test. And if I do it and I look at it and there's agglutination, I'll put a bit more saline on and have another look and see if the agglutination persists.
Yeah.
What's your preferred way of doing it?
Oh, it's tricky, isn't it? Because you've described a 1 to 10, but it's probably quite a lot more dilute than that, given the drops coming out of the syringe.
Yeah, indeed. Because the drop out of the micrometric tube is obviously smaller than the drop out of the syringe.
I will start 1 to 4, because if I've got no evidence of agglutination there, then you don't end up with this slide that's got so much volume on it that's quite tricky to manage. But if it does agglutinate, I'll keep diluting it out. I've probably not got a set number I go to. These are sort of quite subjective tests. You sort of realise it's quite difficult to interpret them, and everyone does them differently.
Yeah.
But I'm always really, really careful to look for macro and microscopic agglutination, just to make sure that anything that looks macroscopically like agglutination isn't inadvertently rouleau, which I think we encounter less in dogs, don't we? But definitely something that's really important to evaluate for.
Yeah, I think it's essential to always look microscopically, because either way, if you think you can see agglutination macroscopically, as Jenny says, you need to check that it's not rouleau microscopically. But equally, if you can't see it macroscopically, that doesn't mean it's not there. So for me, either way, you always have to look microscopically to do a thorough test, I think.
Yeah. And I think we've sort of mentioned in this pathway, we're looking ideally for regenerative anemia, and then our other we've alluded to the fact there are a few causes of hemolysis, or more than a few, but in reality, we mainly deal with sort of fairly small numbers of causes of hemolysis in dogs. But ultimately, our other huge differential group for a regenerative anemia is haemorrhage. So I guess in those patients that are slightly more on the fence with the diagnostic test for IMHA, what do you like to do to sort of feel comfortable that haemorrhage is less likely to be a feature of their disease?
Oh, I was about to ask you the same question, so we'll see what you say in a minute. But for me, I think a rectal exam is essential in these patients, because these are patients that can be having melena and it's not apparent from the history. I think the owners haven't always picked up on it, or it's just not been it's not apparent for whatever reason. And for me, that's such a big differential. And as Jenny said, those that have got like 1+ spherocytes, we can see that with GI hemorrhage. So I think it's really important to do a rectal exam and convince yourself that there's no overt GI hemorrhage, and still bear in mind that if your rectal exam is negative for obvious blood, that doesn't mean that the patient isn't having an acute bleed from, say, for example, a gastric ulcer, and all of it's suddenly bled, and all of that blood is actually still higher up in the GI tract and just hasn't made its way down to the rectum yet. So a negative rectal exam for blood for me doesn't rule out GI hemorrhage, but certainly if you find melena, then that's very helpful. And then I also like to assess for cavitary bleeds. So I like to do a point of care ultrasound of the thorax and the abdomen, even if there's no respiratory signs or the abdomen isn't obviously distended, but just to look for any either pleural effusion or abdominal effusion, which could potentially be blood, to look for other sources of hemorrhage. For me, those are the main places where patients are likely to be bleeding if they're having significant blood loss, anemia, in the absence of other obvious signs that would indicate where they're bleeding, like, for example, if they're really dyspneic and they're bleeding into their lungs.
Yeah, I completely agree. I think that's probably very similar to my approach. I always sort of, whenever I take any history for any case, I always make sure I've asked about all of the body systems, and very occasionally you'll get caught out with a dog that's got sort of nasal or nasopharyngeal bleeding and is swallowing that, and usually, and then they're making sort of pharyngeal noises, and like you say, they would normally have melena, but ultimately not ignoring subtle signs like that, because bleeding anywhere could be sort of really easily masked, especially if they're swallowing it, or
Yeah. And I guess getting a urine sample as well, because I guess that's the other place that they could be losing blood. And then if you get a urine sample that looks grossly like it might be blood, I would always spin that down, because it could be hemoglobinuria, or even myoglobinuria, but you want to spin it down and see if you get a pellet of red cells, which would then suggest that you've got true hemorrhage versus is it just breakdown products, which supports your hemolysis more.
And so I suppose in summary, we will make sure it's a regenerative anemia, ideally by reticulocyte count, but failing that, then we will also look at a blood smear as well to look for polychromatophils and anesocytosis. And then we're looking for confidence that we've got a hemolytic rather than hemorrhagic process. And then we're looking for that extra evidence of immune-mediated destruction, so our spherocytes and our auto-agglutination, I think would be a really, really brief summary.
I think so.
Yeah. Perfect. And then I suppose we haven't really thought about where we go next with these patients. Well, I guess a couple of other things. Do we use anything other than haematology to diagnose them? Because I guess sometimes these patients have got other features as well. And then what do we do about looking for triggers for this disease, and how do we make decisions around those?
I'll let you talk first about other features and what other things you might use.
So I think it's not uncommon to see hemolysis in these patients. So when you spin your microhematocrit tube down, or if you've left your serum tube on the side that the serum's hemolyzed, we'll often see an elevated bilirubin, not always, as a marker of our sort of prehepatic jaundice, essentially, because of the hemolytic process. And then I'll often look at other elements on my sort of biochemistry. So things like a really high urea might suggest to me, actually, I'm dealing with GI hemorrhage instead. And then not to get too led, for me, for mild to moderate increases in hepatic enzymes that could just be hepatic hypoxia if we've got a really, really severe anemia. I think that's probably as much as I use a biochem. There might be other things as well, but they're my main.
I would completely agree with what you said. Those would be my main things. And then I guess the only other thing that we sometimes see is when you're actually either when you're taking the blood, or if it's when it's been in EDTA for a minute or two, is if there's gross agglutination in the tube. And whilst that is not diagnostic in its own right, and there are other things that can cause that, that is a strong indicator that often that will turn out to be an IMHA patient if they are auto-agglutinating in the tube.
Yeah, really helpful. Perfect. And then I guess screening for me, so if I've got clients who are not at all cost limited, and I want to make sure that there's no evidence of an underlying trigger as a disease, I suppose before I get to the stage of doing further diagnostics, the history is really important to me. So any sort of recent drugs, so for me, probably within the last couple of weeks, but potentially up to the last month, includes vaccination, although there's no real evidence that vaccination is necessarily a trigger for IMHA. So always bear that in mind, because I think owners get quite anxious about that as soon as you mention the possibility of that. But new drugs, particularly sort of antibiotics like amoxicillin, clavulanate, cephalosporins, TMPS, but other drugs as well. Non-steroidals, yeah, we've had a case of that this week. And then any other possible toxin in the environment, I suppose. So there's a historical element to me. And then the historical element would also include any other sort of chronic disease this patient's got, and the disease or the drugs of that might be a trigger. And then a travel history. And that's, I suppose, more looking for triggers for or diseases that we know are associated with IMHA. And I guess we'll come on to that in sort of how we screen them. And then if I've got owners who are not at all cost limited, if there's any indicator on my exam that there's a localizing feature, I will chase that as my sort of primary concern. So say, for example, I can palpate an abdominal mass or the dog's tachypnic, but I've got no evidence of sort of any sort of pleural effusion. So whether there's an underlying pulmonary disease that's a trigger, or it's just had a thrombus secondary to its IMHA. But ideally, I will do thoracic and abdominal imaging, usually CT. And I will do a Babesia PCR. I think that is something that is probably, if I'm only allowed to do one infectious disease test, that's the most important for me. And then anaplasma ehrlichia PCRs and a 4DX to do the serology for those as well. I like CT over ultrasound because I'm looking really for sort of metallic foreign bodies, just in case they're a trigger for a possible hemolytic process that's not an IMHA. But yeah. I think that's my screening. I'm happy to treat them unscreened if I can't find anything on examination that suggests to me that there's likely to be a trigger. And that's a situation we often find ourselves in. I'd much rather save the money for treatment and blood transfusions if it's a sort of young to middle-aged dog with no clear trigger from its history and exam than spend all the money screening it and not be able to treat it. I think would be my summary.
Yeah. And I think the only thing I would add to that is just having a really clear conversation with the owner at the outset about finances and what they want to do in terms of level of investigation. Because often the investigation, unless, as Jenny says, there's something really obvious, either on physical exam or a travel history, something that indicates we really should investigate specific things as triggers. But often if it's like a middle-aged spaniel with a classic signalment, it's very likely that it's going to be idiopathic, and often it is low yield to do a full investigation. If the clients are cost limited, like Jenny says, it's better to save that money, but you don't want to get into a situation where you've started treating and then the owners change their mind and want to investigate, because it's so much more difficult to get reliable diagnostic results once you've started treatment. And so I think just having a really clear conversation that once we start treatment, that's to some extent a point of no return, that it's harder to go back and investigate afterwards. So the owners are on board with whatever route we take.
Yeah.
And I like to image the thorax and the abdomen, and the same as Jenny, I prefer to use CT if that's available. If that's not available, for me, radiographs and thoracic radiographs and abdominal ultrasound are fine as a substitute. But I would want to image both body cavities, because one of the main questions that we're asking with that is there a neoplastic process that has gone undetected? And so if you don't image both body areas, you can definitely miss something.
Yeah. And do you screen for anything else over and above the sort of infectious diseases we mentioned?
I quite like to screen for lepto, because it's a common disease. I have seen a number of patients that have, certainly IMHA and concurrent lepto. Whether that's the trigger or not, I guess we don't firmly know, but certainly any infectious disease could be a trigger. And those are patients that, of course, when you immunosuppress them, that goes really badly if they've got underlying leptospirosis. So I do like to test for that. And I like to do a urinalysis to check for UTI, which, again, generally speaking, is quite a low yield test. We don't find many that have that, but just in terms of things that could potentially be a trigger, I like to rule that out.
Yeah. I'm going to be controversial and say I don't do urinalysis unless they've got urinary signs or an azotemia. because I wouldn't treat it if there were no low urinary signs or an azotemia, but maybe I'm missing some triggers.
I think we very rarely find positive.
Yeah. I think that's probably it from a sort of, if we were summarising our approach to diagnosis.
Yeah. Maybe it's worth us just discussing whether we would use a bone marrow biopsy in these patients.
Interesting. So in a robustly peripheral IMHA, so one of our typical IMHAs as we know them, I don't use a bone marrow. I think the times I would consider using a bone marrow is if, so as we all know, these dogs often have a really sort of marked inflammatory response, like they can often have sort of quite a significant neutrophilia with toxic change. I think often that's mistaken for it then being an infectious disease process, but we can see sort of really robust inflammation with sterile diseases, particularly IMHA and pancreatitis and examples. I'd consider a bone marrow if I had any concerns there was a trigger in the bone marrow. So if the patient was neutropenic or a sort of bicytopenic, and I wouldn't include a regenerative anemia in a bicytopenia, like for me, that's happening outside of the marrow, that process. But if the patient was thrombocytopenic and neutropenic, I'd probably check it for Ehrlichia first, but ultimately I'd consider that the neutropenia is really unusual, and if I've not found a septic focus and there's not another cause for the neutropenia, maybe there's a trigger lurking in the bone marrow. If the patient's hypercalcemic, even if their lymph nodes palpate normal, I will definitely FNA as many lymph nodes as I can access, their liver and spleen, and then marrow them as well, in case we do occasionally see sort of leukemias, lymphomas that are infiltrating the marrow and nowhere else, and then they're the trigger. So is that your approach, or were you thinking of other?
Yeah, the same. And then I guess the more difficult ones are the non-regenerative anemias, where it's a bone marrow centric anemia, but they present as a different subset. But for me, those are the ones when then I would do a bone marrow, or as you say, if there's any suspicion based on either a neutropenia or a bicytopenia that there is also a disease process in the marrow that could be the trigger.
Yeah.
I don't know what you do, Jenny. I tend to not do a bone marrow if they just had a thrombocytopenia, though, because I will treat that more as a peripheral process, that they've got immune-mediated destruction of both red cells and platelets peripherally, rather than looking to the bone marrow.
Yeah, so when I said my bicytopenia, I meant platelets and neutrophils. But no, I completely agree. And yeah, I think, and with the PEMAs, I think the only other thing worth mentioning with the PEMAs, so the precursor immune-mediated anemias, that as Helen said, is a completely different disease. They present non-regenerative, usually quite well, with quite marked anemias, but we often see the peripheral features of the immune-mediated destruction. So we often see agglutination, but then a non-regenerative, very marked anemia. And that could just be a sort of very early pre-regenerative phase of a normal IMHA. But if the dog's clinically well and stable, it suggests that anemia has been present for quite a long time and therefore is more likely to be marrow-derived. The only thing I'd say about those dogs is just, and the cats to some extent, but particularly the dogs, is an awareness that the prognosis for that disease probably is quite a lot better than the peripheral IMHA, or certainly not worse. And so just to sort of say, the really severe anemias that have got features of immune-mediated destruction, just bear that in mind. Yeah, I think that's us wrapped up for diagnosis. But we'll see you, depending when you watch it, but maybe in a second for the treatment element. Bye.
Bye.